Many of our fundraising events, as many of you know, were not able to take place because of COVID restrictions. We delayed our golf tournament, and we were able to have our golf tournament, which was a wonderful success. And I've been incredibly impressed the way our community continues to come together, even during these very difficult times. And it's not been easy at the hospital. Certainly not been easy for our patients, and that is the Stand By Our Kids theme. We have kids who are continuing to go into the hospital on a regular basis for treatments, for emergency visits, for regular checkups. All of these things have continued despite the challenges of COVID. So we have kids going into an environment where I was talking to one of our ambassadors, Andy Morrison, the other day, and she was talking about having to check in with the screeners and having to wear a mask, and the impact that this has had on our child life program and the other expressive therapies that are so critical to the care of children. It's really made things challenging. And despite this, as is not unexpected, the Children's Hospital has adapted and come through in so many wonderful ways. We did have the opportunity a while ago to have Dr. Jackie Schleifer-Taylor, the president of Children's Hospital, speak in a similar session to this. And one of the benefits we have as Children's is we're a hospital within a hospital. So tonight we have Dr. Paul Woods, president and CEO of LHSC, and I appreciate you coming tonight, Paul. I know you were in a board meeting immediately prior, and glad you were able to escape and join us. And we'll also hear from Dr. Rod Lim, who is the medical director and section chief of the Pediatric Emergency Department. As well, on the panelist group, you won't see them until the end. But I'm pleased that Nash Syed, the interim VP of Clinical Programs and Integrated Health, and Dr. Craig Campbell, the head of the Division of Pediatric Neurology and the interim co-chair chief of the Department of Peds, is also here. We're joined tonight in the audience as well by many of our volunteers, many of our board members, and certainly many of our donors and supporters, and the key people, the key individuals who stand behind Children's and certainly stand by our kids.
So this is going to be a pretty simple sort of overview. I'm going to give you some numbers and some exciting things, but I really want everybody to take away really three key messages. One is we're really large, and we're really large in size, we're large in impact, and we're large in importance. That's point number one. The second thing is we're really good. We're really good at what we do. We make a big difference. So whether it's in the clinical field, in the populations that we impact over an unbelievably large geography, but also in terms of teaching the next generation of healthcare providers, whether they're physicians or other professional specialties, but also the phenomenal research that we're doing, much of it during this recent COVID thing, just as a validation of that. And the third thing is it's getting even better, and it's going to get better for women and child care in Ontario. And so prior to COVID, there was a lot of things happening. And while it may have lost a little bit, it really hasn't lost its momentum. It's just sat there and idle. So I'm going to talk to you a little about that particular thing. This is me, but I think you don't really want to know about me. So that's just me standing in a hallway. I'm a guy. Family doctor, graduate of University of Western Ontario, now Schulich School of Medicine and Dentistry at Western University, dating myself by saying it was in 1985. So I kind of came home 3 years ago in January of 2018. So we're a very large hospital. And so if you go down about 7 or 8 bullet points, we have 131 medical inpatient beds. And when you count some combination of all these various different things, we are actually the third largest pediatric hospital in Canada. And so some people dispute this, but if you take a look at the 131 beds If you look at the number of inpatient visits that we have, 6,000, 37,000 emergency department visits, 49,000 ambulatory visits, a phenomenally large child and adolescent mental health outpatient footprint, and now an increasing inpatient child and adolescent mental health footprint, growing from 16 psychiatry inpatient beds to 25 with the transfer of beds from across the road at Parkwood, over 90 physicians. This is a very large children's hospital. It's actually, if you take a look at the 144 hospitals in Ontario, we would be in the top third or quarter of that just on the basis of our children's footprint alone. So we are a big deal. We have a huge impact. Well, how big an impact do we have? I don't know, because it won't let me advance the slide. There we go. That's how big it is. And so if you take a look on the right, or at the very bottom of that, we think we're very large in southwestern Ontario. Kind of Southern Ontario has been accused of those elsewhere in Canada being the center of the universe. But you take a look in the right hand, and then you go over to the left hand map, and that little area is absolutely dwarfed by what is above it. So we have this, if you look at the old LHINs, which still exist to some degree, LHINs 1, 2, and part of 3, most of the pediatric specialty care that we provide is in that footprint. But then if you go up into the former LHINs 13 and 14, by the way, right about where my cursor is right now, halfway between Thunder Bay and the Manitoba border is Dryden, Ontario, where I used to live and where I used to practice medicine. You look at that area, and it's really the size of Switzerland and represents a total population of 2.3 million people. So the impact of this is unbelievable. Bringing it down home to what that impact is, when I used to practice up here where that arrow is in northwestern Ontario and Dryden, we had no pediatricians, we had no neonatologists, and we would periodically have a baby that was born at 27 or 28 weeks. And I can't tell you, as a family doctor in Dryden, Ontario, trying to beg a baby that weighed a couple of pounds, the relief I got when that neonatal transport team came walking in the door with their paramedics and their transport nurses, and often with a physician. And that's the kind of impact that we have. So our transport team is the first neonatal pediatric transport team in Canada, which safely transports neonates and children up to age 18. We have outpatient clinics through all of the region on the right. And certainly there is, in the long term, the possibility that we would be able to assist with some things that are happening up here in northwestern Ontario. We have a simulation center training for community hospital staff in their own hospital. So the Children's Hospital supports an enormous number of children over enormous geography. And again, if you're a resident in Pickle Lake or Fort Hope, you're awfully glad for the Children's Hospital. Children's Hospital, where is it? Well, most people recognize this sign, the bear. Everybody loves the bear. I love the bear. Look at it, smile every time I see it. It's located within the Victoria Hospital campus, and it's in what's called a proverbial hospital within a hospital. Some people view that as a regressive step. That's actually the direction of most children's hospitals, and there are several reasons for it. Some of them are sort of clinical and strategic, and some of them are operational, tactical, and efficiency related. So if you look at women's care, often happen in large general hospitals like Victoria Hospital on the right. And so prenatal care, antenatal care, intrapartum care, perinatal care happening at those points as they transition from being a product of a pregnancy to actually being neonate. And so there's that. There's the other end of it, as there's the maturation of children with chronic disease or with chronic conditions that are matured into the community. So that's the sort of strategic and clinical rationale for the children's hospital within the hospital. But the reason why a lot of places are going that way is just efficiency in terms of infrastructure and support services and that sort of thing. So it's actually not a regressive or a sort of a second, sort of a redheaded stepchild phenomenon. In fact, it's actually the way strategically most places are going. So a number of years ago, 3.5 years ago, I interviewed at LHSC, and I expressed some concern about what is the identity of the Children's Hospital. I had trained here when there was a children's hospital, which some of you remember called the War Memorial Children's Hospital. And then I left, and this building on the right sprung up at the corner of Commissioners in Wellington, and it became Children's Hospital of Western Ontario. But then something happened, and we began referring to it as Children's Hospital. And so my question when I was interviewing is that the right identity for the group of providers, the programs, the services, the support staff, et cetera? So to that end, the department itself, going rogue, as they often do, contracted with Corpus Sanchez a couple of years ago. And in January 2019, Corpus Sanchez tabled a report called Defining a Future State Operating Model for the Children's Hospital and London Health Sciences Centre. So while this had not come from me per se, I was extremely glad it happened, because it really gave us a platform from which to sort of articulate where the future of the children's hospital should go. There is a bit of an existential dichotomy in children's hospitals. Are they programs in a general hospital, or is it in fact something different? And I would say that according to biology, medicine, science, and logic, actually, it is a completely different group of patients. So as such, it needs to be something completely different, set apart from just another clinical program. Not that there's anything wrong with other clinical programs, but it actually isn't that. And that's indeed what the Corpus Sanchez report showed us. And so key recommendations that came forth was the need to establish a clear children's hospital brand. And the brand, of course, is about identity. It's not that we're necessarily selling something to a consumer, but what is the image? What are the values? What are the characteristics that spring into people's mind when you mention that particular thing, in which this case, Children's Hospital or Children's Hospital Western Ontario, if you go back to the old name. There was a need to establish a children's hospital leadership structure, to complete a strategic plan, and to create a governance structure. So those were the sort of the 4 key recommendations or pillars of how to go forward. So we've started down the path, and if you look at this sign, this is a sign for Victoria Hospital. There actually isn't really much of an indicator that that there is a children's hospital, in fact, contained in that campus. There is emergency for adults and children, but that again does not necessarily translate to there's a children's hospital here. So accordingly, a new leadership structure commissioned a pre-branding structure. And one of the things that was brought to the Children's Hospital Committee of the Board was a 3-phased approach to articulating our identity and brand as a children's hospital. And part of that first stage was some preliminary work that was done. So some of the things that we discovered during that time is that we needed to establish a brand. And we started along the journey, and there was a lot of engagement with the people. And it was really important that, well, it's important that what people like me think, it's important what donors and supporters do. It was really important that the people that work there actually had a chance to say, what do we think we are? What is our story? And there were some fantastic kind of themes that came out of it. So the best story never told was the desire to own and communicate the potential of children's. And so again, is this just a program in a general hospital, or is it in fact a different thing that manages the tertiary and quaternary end of an entire continuum of care? It was felt that there was ever a time, this was the time. So the leadership within LHSC, the leadership in the Children's Hospital, Dr. Jackie Schleifer-Taylor, and that sort of thing, that the desire to own, or the internal readiness and the respect for that leadership, Jackie and others within the Children's was never higher. There was clearly an immense pride within and a perception of quality, fantastic care from without. So those who were viewing the Children's Hospital were looking and saying, this is fantastic care. And there was this enormous pride internally. That there was a little bit of a disconnect that while we believe we are a world-class children's hospital, and the data would support that we didn't necessarily articulate that to the extent that it generated a reputation. the together and apart thing, that could we as a children's hospital have our own identity and our own brand and yet still be part of the LHSC family. The importance of the difference between child focused and child friendly. Every hospital everywhere in the world should be child friendly, but child focused is a unique characteristic of a children's hospital. And can you do it if you're a program in a children's hospital, in a general hospital versus a separate children's hospital? And there was this enormous sense of team pride, unity, respect, and collegiality within the children's hospital team. So it was a great report to sort of be part of that phase one of the brand and identity exercise. One of the things was we believed, and when we benchmarked externally, that we were grossly undermanned in terms of our leadership structure. By far, the least well-resourced children's hospital in Ontario. It wasn't even close, and even looking outside. And so this is the current leadership team, and there would have been 2 pictures on that page a year ago. Of course, Jackie Schleifer-Taylor, Executive Vice President, Chief Clinical Officer for LHSC and President of the Children's Hospital. Nash Syed, who has done a phenomenal job as the Interim Vice President, Clinical Programs and Integrated Care. And we're very excited to not say goodbye to Nash because we wish he would stay forever, but given that he has to move on with his life and do other things and help other health systems, we're very close to hiring a permanent vice president of clinical programs for integrated care. Emily Williams, internally developed, phenomenal director, and that is her title there, and Deb Wiseman. The sad face part of this story is both Emily and Deb have accepted positions, promotions in other places, which bespeak their enormous talent and competence that they have. And we're very hopeful that we will be able to replace Emily and Deb with people who are hopefully even almost as great as they are, and we wish them the best. But this is a much more robust leadership structure than what we had before. And we have moved into a stage with our medical leadership where we decided to internally fill the role and to make it a co-chair chief role between Dr. Ram Singh and Dr. Craig Campbell. And I have to say, of all of these sort of internal promotions that I have seen in my years in healthcare leadership, these 2 guys stepping forward, boldly embracing what is in front of them, to lean into the challenges in front of them, to fearlessly lead the group that they are leading, but also to work with leadership in the rest of LHSC to make some workable solutions has been phenomenal. And I'm so bullish on these guys. They are so talented and they're so committed. It's been wonderful. In terms of a strategic plan, one of the things that I initially thought of, and it was very much validated by Corpus Sanchez, was the need to have a separate strategic plan. So if you look at LHSC's strategic plan, it doesn't include anything that's specifically related to children. And children are not just small adults, they're a completely different population. If you look at how you would strategize to impact the health of them, if you would look at how you would make resources or make investments and allocate resources, it's completely different. So we believe that's part of the near future, is this notion of having a separate strategic plan for the Children's Hospital. So here are some of the strategic priorities that we have right now. But as we start to move into this notion of a regional health integration team, which is I'll tell you about in a second, the notion that we would be sort of the anchor of a system of care that encompasses that enormous geography that I spoke of before. That's really what we're looking at. So these are some of the programs that we're doing and we're engaging in. The regional health integration team is something that was really, I have to give Jackie the credit for this being her brainchild as we were looking at Ontario health teams in the province. And her notion of bringing forward an integration of healthcare providers like ourselves, smaller hospitals, primary care, places like Thames Valley Children's Center, a phenomenally successful and valuable partner in children with high needs and that sort of thing. The notion of banding these groups together to create a system of care instead of just a bunch of healthcare providers who agree to collaborate and work with each other to actually say, how can we do a much better job? So there are phenomenal conversations that are happening with this as well. So I'll just go on to the last thing here. Scott's probably tapping his watch. I can't see him, but I suspect he is this notion of children's hospital governance. So one of our successes was last year to establish a children's hospital governance of the board. Typically, a board committee would have a component of the overall operations of the hospital. So those are the committee's governance, finance and audit, quality and performance management, and people and culture. So it's cross-cutting across all our clinical programs and that sort of thing, but actually functionally relatively limited. This Children's Hospital Committee is more like a board within a board, kind of like the hospital within a hospital. And while it is not a separate corporate entity, so as such under the Public Hospitals Act does not have its own board, the vision is that eventually it should function like that. So if you believe that that the Children's Hospital should have a strategic plan, it would be accountable for the delivery on that strategic plan. If you believe that it should have a carved off separated funding envelope, and there's at least one person on this call, me, I'm holding up my hand, then it would be accountable for the fiduciary delivery of services within that. So that is, I believe, the long-term vision of what will be achieved. Right now, it's more focused on strategy and the vision and alignment with the regional health integration work that I just alluded to. A lot of talk about quality and safety, and I can say of all of the hospital committees that I get the privilege of being ex officio on this group leads the pack on being extraordinarily passionate and child-focused. Again, not child-friendly, but child-focused. There's much more to come on governance. There's much more to come on strategy. I think this is an incredibly exciting time to be involved with child health care, and particularly with our vision of aligning it with women's health and the 1,000-day model, which Jackie would be glad to regale you with the story of at some point. I think it's an exciting time in Ontario to be in healthcare in general, but particularly in the care of children. So thank you so much for listening.
So the other piece that we wanted to do was have an opportunity to hear from Dr. Lim, who really is, we see all the signs around the community that say we are behind our frontline healthcare workers. Well, Dr. Lim sees on a regular basis just exactly what that means, as he's in the PEDS Emerge. And as well as that, Dr. Lim has had a tremendous, has presented a tremendous knowledge of the impact of COVID-19 and how it's affecting our communities and how it's running through our society.
I thank the foundation very much for this opportunity to speak and really just share with you a little bit about our experience over the past few months dealing with the COVID-19 pandemic. And I come here not as just an individual, but really just representing an amazing group of people at Children's Hospital that care very much about the children that are coming through our doors and really trying to advocate in all types of avenues for their well-being, their physical health, their mental health, and their experience in navigating the healthcare system. Despite the overwhelming nature of COVID-19, other diseases don't stop, unfortunately, and it just adds to so much more complexity to trying to help these children navigate it. So I'm just going to take you not to create some PTSD in people, because I'm sure everyone's thinking about COVID a lot. It's all we can kind of think about it, no matter what's going on. But I'm just going to navigate this a little bit chronologically, just to highlight some of the things that we have been thinking about in the front line, some of our experiences, and some of the things that we've tried to think about and predict in order to best meet the needs of the children in our community, and also to really partner with so many important other organizations that are involved with child health for the betterment of our community. And this has clearly accelerated a lot of these partnerships, and people have been so willing to be on the same page and trying to do the right thing. And I think just, in general, these challenges, you really do see values come through for good and for bad during these kind of once in a lifetime events. But I think character comes through, and I cannot be more proud of our team at Children's Hospital in terms of the way they've responded and just the dedication and the courage that they show every day at work through very, very trying times. Advance my slide here. So taking us way back to March, and it seems like a lifetime ago, right around March break, but there was just absolutely so much uncertainty, and things that we had developed over years, had become very comfortable with, how we manage airways in the emergency department, the way children navigate through our emergency department, where they can go, our infection control protocols, they were all completely thrown out the window. And back then there was so much uncertainty as to what was safe and not safe. We never had to deal in my career in terms of shortage of PPE. We never had to deal with not really knowing what type of procedures would get ourselves into trouble. And much like with the baby boomers retiring, our pediatric emergency department actually is staffed by quite a young group of allied health professionals. And you can imagine it starting your job 2 years, 3 years into your job as, let's say, a nurse or a starting physician, and then being faced with this where really your own personal health is at risk. And I have to say that they did not blink. They absolutely came to work and accepted a lot of the uncertainty, and we really just tried together to bond together as a team and try to make the best decision with the information that we had. There were so many protocol changes, just countless protocol changes, where things you would just take for granted. I'm just going to advance my slide real quickly and come back to this. But this is a sign that I just took a picture of today in our resuscitation room. And in those medical shows where everyone has to clear and they defibrillate the patient, and if you happen to be touching the patient, you'd be shocked. So everyone knows to yell clear, and you do whatnot. Things that we would just normally react to, where we just say, geez, that person's not breathing, we're going to have to start bagging the patient to help them breathe, was completely thrown out the window. If everyone's wearing the wrong PPE, everyone would have to rush out the door. You'd have to strip down. You'd have to change your mask to an N95 mask. You'd have to put on special gloves, special gown, special goggles, special mask. And just the protocols to do this, you can imagine, we had to balance how do we keep ourselves safe and then not let a patient come to harm, not let a child come to harm. So we developed all these pauses and protocols and things like that were just to do our basic function of business that completely just disrupted us. And the number of the quick actions and coming up with the best evidence, we really did embrace that patient safety quality initiative. We have a very excellent sim program where we have the mannequin and a simulation program. And basically we ran sims every day, drilling all these new protocols and learning how some of our assumptions were completely wrong. And basically we almost have like a NASCAR setup now, basically with these identical donning stations. We have an officer that watches everything. And as soon as someone goes into that room, we have a protocol of someone going into the room. Everyone basically changes together into protective equipment. You get checked by the donning officer, and then you go in and you're ready to take care of the patient. So we had to drill it much like a pit stop in order to get good at it, because these were completely new protocols. And again, thank God for our sim teams and for the dedication of our staff to keep learning or whatnot, so that this became second nature. And so now when we do it, it's almost second nature after a few months. But at the time, it was an absolute disruption to the things we did. At the time, because of lack of PPE, we really had to decide about essential staff and non-essential staff. We sent learners home, medical students stopped coming to the hospital. Non-essential residents were shifted away. But just again, around character and values, we never sent home child life. And as you know, the Children's Health Foundation has been an incredible supporter of child life. And we felt that their role in the emergency department in the pandemic to comfort these children and help them through difficult procedures in a time of fear was essential. And I'm very proud of that decision. And I think it's one of those things where, as I said, in crisis, your values come through. And the experience of the children and ensuring that they could navigate our emergency department in the most humane way possible was absolutely paramount on our mind. At the time, in the beginning, information on children and COVID were really unknown. Everyone always said, children don't get COVID or whatnot. The experience from Wuhan was very limited. So we didn't have a lot of information. We made a decision very early on, because of the asymptomatic spreading of COVID, that every patient we see, we need to be in PPE in the emergency department, because they're all undifferentiated. And it was a great decision, because of most of the COVID cases that have come through our emergency department have been in patients you would never have guessed had COVID. and we were able to protect our staff because of that decision. It was very proactive, and I'm very proud that we used the evidence at hand to be proactive with infection control. And I believe it's spared our staff from potentially exposure. We offered for our wise doctors, I don't want to say older doctors, but our wise doctors, alternate work arrangements because we knew that it was a high-risk environment, and we were very sensitive to the fact that they would be putting their lives at risk working, especially in a peds emergency department where you don't know who has COVID and who doesn't. The hospital was amazing. They volunteered to divert high-risk patients away from our department during COVID. So patients undergoing oncology or chemotherapy or coming in for those kind of concerns would normally come through our emergency department, and the oncologists volunteered to cover double call and basically divert them away from our department so they wouldn't be coming through in high-risk area. And one of our greatest things was a mental health diversion where the psychiatrist would agree to do a virtual clinic urgently. And they would get an appointment within 1 to 2 days, which is far superior than what was available prior to COVID. And this has been a tremendous success for our region. It's a tremendous service to the children. And in fact, it's going to be researched across the country. And I think I really hope that it's here to stay because it's a fantastic model and a fantastic service to the children. I can't tell you how much of an effect on mental health that I really worry about COVID in children. Early on, we were seeing children come in with, these are children that would not have had any previous visits, and their safety valve was to not be in the house. They would find a way to be involved in sports or in school or whatnot. And when the quarantine hit, we saw tremendous amounts of very unfortunate abuse and very, very unsafe households that these children were subject to because of quarantine. And we were very much advocating for helping them as best we could in a very, very difficult time. We had an incredible drastic drop in our visits. Overnight, we went from maybe about 100, 110 a day down to 25 visits a day. Everyone was terrified, absolutely terrified of coming to our emergency department. And we knew from previous experience that people avoided emergency departments and actually presented delayed with diabetes or delayed with cancer, and children were having horrible outcomes. And we had a couple of unfortunate outcomes, which were delayed presentations because of fear of coming to the department. And we tried to put our heads together, and we basically tried, with incredible support from the hospital, created very quickly a virtual clinic, which has been incredibly received by the community. We've seen over 600 patients through the virtual clinic. And we have about a 93% approval rating of satisfied to very satisfied, a great ability to complete the visit, and the public gratitude has been overwhelming. It's just been an absolute profound success, and I really thank my group for stepping up. We really set up the model without knowing how they would be rewarded in terms of financially, and they really didn't care, to be honest with you. They just tried to do their best during this time. So. It was I think one of the best jump starts for virtual care, and as Dr. Woods was saying, we're really hoping that we're able to expand it to actually help more of Ontario than our traditional geographic region, and be a leader for virtual care for children and lead the way. So a great opportunity, and I think excellent care, and hopefully it can expand into the north, where really that expertise would be extremely well received. Lots of equipment. When we have to intubate patients, we really do have to make sure that we keep our distance away from patients. So we use technology to do that. We have ultrasound and things like that. We had to adapt protocols to do that. We really had to adjust the physical structure of our emergency department to create infection control spaces and create negative pressure spaces in order to see patients at high risk of COVID. And so that was, these are all temporary walls that were put up very quickly, and were tremendously helpful for us to adapt quickly to phase one. So just quickly, just a little bit of history in terms of what we're expecting. So a little bit about R factor. So R factor is the reproductive factor. It's the ability of COVID from one case to spread to 2 cases. So the normal R factor is thought to be 2. So for every 1 case of COVID, if you don't do anything, there's going to be 2 people with COVID, then 4 people with COVID, then 8 people with COVID, or what we call exponential growth. And certainly we saw a lot of growth during phase 1. And then we had the flattening of curve with phase 2. And no one really knew if that was because we did a great job. We certainly, the quarantine was an amazing thing, but we didn't know if the factor was weather. We know when temperatures get warm, our factor goes down. When temperature gets cold, our factor goes up. That's why the flu is a winter phenomenon. And that's what the origins of phase 2 are. This is the R factor for Ontario currently, and that blue line is where you want to be. You want to be under it. And unfortunately, for quite a number of weeks now, we have been over an R factor of 1. This is just to illustrate the R factor for different states. Those are all northern states in America, which never got over phase 1, and they're just starting phase 2, and they're in a very horrible situation. But you can see a lot of the northern states are having the exact same peak that we're seeing with phase 2. The reason America had such a high peak in the summer is we have the reverse R phenomenon in the south. When air conditioning is on in a very hot climate, people tend to congregate indoors. So the states you heard about, like Texas and Florida and Mississippi, Louisiana, that were having trouble, are doing fine now because now they're into the parts where their weather is not overwhelming. So that's why America for a while had a really bad cases, and it looked like they were getting better as the southern states were getting better, and now the northern states are coming and they're gonna take off. Just in terms of cases, just as a quick lesson, we didn't test enough in the early times to really have accurate. The only people that we really tested in phase 1 were patients that were going to be admitted. So really, when you think about hospitalizations, if you look at the curve there with hospitalizations, that's the light blue graph, we're still probably about a third of the way of how bad we were in phase 1 currently. So certainly we know about lots of cases right now, but we're nowhere near as bad as we were in phase 1. With exponential growth because we just didn't test enough during that time. The curves there represents new cases, and as you know, and if you've been following the news, unfortunately, we're not doing particularly well in Ontario, but other provinces are doing much worse. Saskatchewan and Manitoba and Alberta are particularly in deep trouble right now. This is just a graph showing some tests, and we know that we had a testing backlog, especially with the start of school. We really did reach out, and we really tried to be very active as a children's hospital. We reached out to the school boards in the Middlesex London Health Unit, and we worked together to try to come up with screening guidelines. We advocated for the mid-turbinate swabs, so the swabs would be much less invasive for children, and that was agreed upon. That was on advocacy of the children's hospital in our region, and we worked together with them to try to create parental handouts. So the ones that you saw from Middlesex London Health Unit and whatnot, those were a collaboration with us in order to try to educate parents as to when they needed swabbing. We also work with Ontario West region with the family doctors, and we created a symptom flow sheet for the family doctors in order for them to know, geez, do I test with a headache for 10 minutes? Do I test with a headache with 5 hours? And we tried to standardize for that in order to help them best interpret it and create some standard of care and some consistency for children in our region. The big worrisome thing here is test positivity. That's the orange line you see there. So for every 100 tests, that's the number of tests that are coming back positive. And you can see we're heading in the wrong direction. Disease is increasing, not decreasing. That's consistent with the R factor that we presented. And just for comparison, in Peel region, the test positivity rate currently is 10%. This is a sign of capacity, and we are doing, fortunately, reasonably well in Middlesex London Health Unit, but you can see that our hospitalizations are increasing, our ICU is increasing, and our ventilations are increasing. And the ministry today just released a projection, depending on 3% or 5% growth, and estimating in terms of ICU capacity by mid-December. That was released in the news today. As you know, Middlesex London Health Unit and this region has been doing pretty well compared to Peel and Toronto and Ottawa and Kitchener and Hamilton or whatnot, but we have had a very bad week in the past week or 10 days, and we seem to be consistently running about 20 cases a day now. So, how do we leverage what's going to happen to try to advocate the best for children in our region and try to be proactive? We're not alone. I don't want you to feel horrible, but maybe this is not very reassuring, but Ontario right now, we're averaging 52.1 cases per 100,000. And you can see some countries like France and other places or whatnot are in the 588s. So very, very much increased. And Canada overall is averaging much higher with Manitoba, unfortunately, leading the way. This is a very useful, I applaud the government for coming up with a color-coded system. As you know, London is currently in green, or what we call prevent. Yellow, protect, orange, restricted, and red is control. And currently Peel and Toronto are maintaining in the control section. But as you know, the last couple of weeks have been poor, and we are likely going to be heading into to a yellow region in London soon. This has ramifications for business hours and types of businesses and things like that. Where it affects children is, we know after we see a peak of COVID, acutely, most children don't do poorly, but the one thing that we do worry about is something called multisystem inflammatory disorder, which can present as a very serious vasculitis and can affect the heart. So there have been deaths related to the vasculitis in children. It's rare, but anytime you see a peak, you always have to worry that you're going to see this probably a week or two after, and up to 4 to 6 weeks. So we know numbers are increasing in our region, and we're certainly keeping an eye out for this. We have advocated and we've worked together, and we've created an MISC document for our region to help our family doctors know when to refer to a children's hospital and our regional partners. So we're really trying to reach out to them and be that knowledge for our community and provide that information to them, so that children, no matter where you are in Southwestern Ontario, are going to get excellent care and know who to contact. Schools have been a very hot topic. We're, as I said, very proud to work with the school boards and try to provide them information. That's the first time I've ever worked with the school boards, and they have been extremely grateful for our participation. We've also helped them in terms of giving advice around patients with high medical needs. So that kind of partnership, we love expanding beyond our walls and really trying to advocate for children throughout our region, whatever they're doing. As you know, there's COVID in schools. My 2 cents, which isn't worth 2 cents, is that overall it's just mirrored community. So I think there hasn't been a lot of outbreaks in schools, but certainly in areas with higher COVID, you're going to have higher COVID in schools. And that's what certainly has played out. The vast majority of these schools cases that have happened have been in Toronto and Peel. So what are we trying to anticipate in terms of a Children's Hospital Emergency Department? As I mentioned, MISC, we've created protocols, and we've worked interdisciplinary with the fantastic doctors at Children's Hospital. We have a protocol that involves many subspecialty services, cardiology, hematology, rheumatology, infectious diseases, so that we know when these patients arrive, what the best way to treat them, standardize the testing that needs to be done, and have an understanding of the type of medications that should be administered. So we've done that proactively in anticipation of any children presenting in our region with multisystem inflammatory disease in children, in order to not invent the wheel, which never works very well at 2 a.m. on a Saturday, in my experience. Space has been a tremendous difficulty because of social distancing, and you can imagine social distancing with young children is even harder. I was going to say we've been very creative, and we've expanded beyond the traditional confines of our department. We've seconded a hallway in order to anticipate a winter waiting room space for the times that we're overwhelmed in order to maintain social distancing. And we've recently expanded in the nighttime hours for 6 hours into the traditional PMDU in the late hours in order to bring an ambulatory care area of additional 18 beds, so that we can get patients in and out quickly and try to preserve flow in our department and keep children safely separated for infection control purposes. So our footprint has become quite spread out through the hospital. We've tried to be very creative. We've always struggled with our physical plant, but we've had great partners who have helped us be creative in order to try to meet the needs of the children. I just want to say that the honor I have to work with the team, it's been a lot of my effort is to really just try to keep their spirits high in a tremendous time of uncertainty. The grind of this has been very difficult on us, and the changes have been very difficult to us, but I've just been so impressed by their professionalism and their dedication to children. And Dr. Woods mentioned the Comfort Promise, which is a promise to our community of the types of things that we're going to offer to minimize any kind of painful needle pokes. And during this pandemic, we've continued to try to institute this and do this. We did not suspend it. We felt it was important, and we've moved forward to try to do it because at the end of the day, we all are incredibly passionate about children, and we want to give them the best possible care regardless of the situation. So I couldn't be more proud of my team. It's a team within an incredible children's hospital with incredible, passionate people, great leaders, and again, I thank you for this opportunity to talk. I'm just going to end with this slide. I thought to myself, how are we going to remember this in 10 years? So I took a picture of all my entire team with their masks on, and I created this collage of them with the Children's Hospital in the background. And I thought, won't this be a memory when we're allowed to travel again, we're on a beach and we can look at this picture and think back of this crazy time that we all had to go through. So I'm going to stop there, and I thank you very much.
There was a question, I believe, Dr. Wood, you answered it directly regarding pediatric surgery within the confines of Children's Hospital. I don't know if, for the benefit of the rest of the crowd, either you or Dr. Campbell wanted to share your answer on that piece. And I would invite anyone else. We have a few more minutes. You guys were great. Right to the schedule. Thank you. So we've got some additional time as planned for questions, should other people have questions. But Dr. Woods or Dr. Campbell?
Well, I know what Craig is going to say, but Craig does not know what I'm going to say. So I do have a decided advantage here, and I'll let you go, Craig. So if you buy the sort of the premise under which child and adolescent mental health was moved from the Department of Psychiatry, from Parkwood Hospital into the Children's Hospital. So if you believe that it is, that children are not small adults, and that it's a separate system of care, whether you want to define it that way or not, the activities, the sort of the clinical, care models and that sort of thing really define it, then it makes the most sense. And I don't want to get quoted on this and have people, the chair chief of surgery to come in and say, I hear you're trying to gut my department. But the reality is if you believe that child and adolescent mental health came over because it made the most sense, because the children that we care for child and adolescent mental health issues also have other health issues related to childcare, it kind of falls in the same thing. So that's me shooting from the hip. I don't want to be held to it, but Craig, I doubt you disagree, but glad to listen to your opinion.
No, absolutely. Thanks, Paul. And, I think one of the incredible things about, working in child health and maybe this is why
Dr. Campbell,
it is, it's who care for children and families. And I don't know, sorry, I'm breaking up there, but I can assure you that through the pandemic, we opted to think and act like a children's hospital rather than separate departments, and we created processes where the critical leaders in all our departments, whether it be surgery, mental health, radiology, emergency medicine, would come together on a regular basis to share their experiences and create, forward thinking that allowed us to deal with the pandemic. And that, that commitment to child health even went beyond creating links within departments, but as Dr. Lim had mentioned, reaching out into the community and thinking of child health in a more systematic way. And so, that's where our heart is, to think and act like a children's hospital, not only through the rest of the challenging times of the pandemic, but well into the future.
Thank you. And certainly from Children's Health Foundation's perspective, we support a great many things within the Department of Surgery, within child and adolescent mental health, surgery, especially with equipment needs and different programs like that. So from our point of view, it operates within already. I don't see any other questions popping up. Oh, sorry, I do see another question popping up. Is there a role for youth volunteer peers to play via Zoom to support the mental health of children and youth? I'm on the youth philanthropy team for the Children's Health Foundation. So excellent question. What can other youth in the community do to help their peers? Is that something we can look at?
I think, if I can speak to that, Scott, I think there's a, tremendous appetite, from all people to share their experience, through this. And I think our youth are especially well positioned to do that. They're more familiar with virtual interactions. They create strong bonds in that environment. And I'll be honest, I work closely with the mental health team, and they've been very innovative to look at ways to connect people, youth and youth with people who can help them grapple with some of the mental health things. So we do have a strong child and youth advisory committee within the hospital as well, and I think those those are the bodies that can be approached to find avenues to make sure that people can be helpful for others.
Dr. Campbell, thank you very much. Nash, I don't know, you've got your sweatshirt on
already.
Are you a hoodie? Looking good there, standing by our kids. I've got my Yeti mug here, so we can turn this into a commercial. www.childhealth.ca. Apparently, we've already had some orders come in, so thank you. It makes a big difference, and most importantly, it sends a strong message to the community that we do stand behind our kids. So I do have another question that came in, but Nash, I just wondered if you had any comments or anything to add.
I would first of all like to thank everybody for taking the time. I've had the benefit of working in a lot of children's hospitals, IWK out east, BC Children's, Alberta Children's. I can honestly say I've never seen a Children's Hospital Foundation as dedicated to the supporting the hospital. I mean, Scott knows as recent as a few hours ago, I reached out to him and I got a reply back within seconds. I was just blown away. And so the CHF is more than just a valued partner. It really is part of the family. I thank the work for the foundation that they do every day. And I thank all the people who are on this call and who support both with time and contributions. That there isn't much that could happen if the foundation wasn't as strong and as stable and as much of a partner as it is. So I just really want to thank everybody. Incredible job.
Well, thank you, Nash. I blushed earlier with your email. I'll blush again. I'll blush again now. But it's a very important partnership. And as I say to our board leadership, and I say to our staff team and our volunteers, we're doing incredibly important work. And what is so wonderful is it is truly appreciated because it makes a difference, and that's great. We have one more question, I think, and then we'll have to wrap it up. And Nash, we've had conversations around this, I think, in general terms. But the question is, will there be a separate space within the new emergency department for a specific setup and programming for kids coming in with mental health issues, kids who may have acute mental health symptoms but do not require medical intervention?
I could start. The goal would be yes. And as you look at sort of contemporary mental health and addiction spaces, especially in the child and adolescent space, it will look very different than what you see today. The rooms, the structures, and Rod could probably speak to it much better than I can, but it's a very different space and it's a great opportunity. It's a growing need and it's an area that we need to sort of think about very differently. So I absolutely would say yes.
Yeah, I think, I think one of the biggest opportunities anytime you're talking about a potentially a new space is to really try to think about the types of people that come through and who is not served well. And I think, when it comes to pediatrics, which really spans the 1-day-old baby or to 2-hour-old baby, all the way up to the teenager coming in with who may be living on their own and suffering from a lot of difficulties. You really want a space that's going to really respect that. And I think right now it's very difficult to separate that. And so we wanted to create spaces that really work for our population. And I think these kind of things provide a great opportunity. And I think this pandemic has really highlighted, probably more than ever, the importance of youth mental health and the way we really need to be purposeful with it and really advocate for it and base decisions on it. We've seen that with school opening. We see that with activity restriction. We saw it with the quarantine. All these things have had profound effects on pediatric mental health. And there's just so much work to be done to advocate for that.
Thank you. Rod, Paul, Craig, Nash, thank you all so much. To the attendees, although I can't see you, I know that you're there. I would like to thank you for joining us this evening. We hope to do more of these sessions on different things that might be of interest to our wide base of supporters. Thoroughly appreciate all the support. It makes a big difference, as you've seen, and as I say, it takes a village, and folks, we are that village. So thank you.